Welcome to The Explainer. Today, we're going to do a high-yield review of renal cell carcinoma, and we're structuring this to perfectly mirror the BCOP exam blueprint.
So here's the plan. We'll start with the foundational science, then we'll walk through treatment for both localized and metastatic disease, and we'll finish up with some really key practice pearls for managing your patients. Okay, let's just dive right in.
All right, first up, let's lay down the groundwork. We're going to cover the core biology and the risk stratification of RCC, and this maps directly to domain 1 of that BCOP outline.
Okay, so here is the one mechanism you absolutely have to remember. Think of the VHL gene as the brake pedal for cell growth. When it's working properly, it keeps another protein, high F, totally in check. But in most cases of clear cell RCC, that VHL brake is just broken. So high F starts to build up, and it essentially slams its foot on the gas pedal, flooding the system with growth factors like VGF. And what does VGF do? It builds new blood vessels and just fuels the tumor. It's this exact pathway that our most effective drugs are designed to target.
And you know, this chart makes a really crucial point just by looking at it. Clear cell is king. I mean, at 75% of all cases, it's what you're going to see over and over again in practice and on the exam. This dominance is exactly why pretty much all of the game-changing clinical trials and therapies are focused right here.
Now, this slide lays out the IMDC criteria, also known as Hang's criteria, which are absolutely essential for choosing first-line therapy. You really need to know these 6 factors cold: poor performance status, a short time, less than a year from diagnosis to needing treatment, anemia, high calcium, and then elevated neutrophils or platelets. It's simple, we just count them up. 0 factors means favorable risk, 1 to 2 is intermediate, and 3 or more puts a patient in the poor risk category. The stratification determines everything that comes next.
Okay, so let's see how this all builds into managing localized disease. We're going to focus on the evidence for adjuvant therapy, which comes straight from domain 2.
All right, here's a classic exam-style question for you. A patient has their kidney removed for high-risk disease. So, what do we do next? Do we just watch and wait, or do we jump in with adjuvant therapy to try and cut down that risk of recurrence?
So here's the head-to-head comparison on adjuvant therapy. Now, both sunitinib and pembrolizumab are technically FDA approved, but the NCCN guidelines draw a very clear line in the sand. Sunitinib, yeah, it improved disease-free survival, but it never proved it actually helped patients live longer, and let me tell you, it's tough to tolerate. That's why it gets a Category 3 recommendation. Pembrolizumab, on the other hand, also has a strong DFS benefit, but with promising overall survival data and a much better side effect profile. That makes it the clear Category 2A choice for these high-risk patients.
Okay, now we're getting into the heaviest weighted section, first-line treatment of metastatic clear cell RCC. This is the core of domain 2, and it's an area where the treatment landscape has been completely transformed over just the last few years.
Let's start with a specific group, the favorable risk patients. Now remember, these are the folks with 0 of those IMDC risk factors. What are our top-tier Category 1 options for them?
The answer is these 3 powerhouse TKI plus immunotherapy combinations. You've got lenvatinib plus pembrolizumab from the CLEAR trial, cabozantinib plus nivolumab from CheckMate 9ER, and axitinib plus pembrolizumab from Keynote 426. All 3 of them blew the old standard of care, sunitinib by itself, out of the water, showing superior efficacy in both overall survival and progression-free survival.
Okay, so what if our patient isn't in that favorable risk bucket? What if they fall into the intermediate or poor risk category? We're talking about patients with 1 or more of those IMDC risk factors. Does our toolkit get any bigger?
Oh, yes, it does. In addition to those 3 TKI/IO combos we just talked about, we add another huge player to the list, the dual immunotherapy regimen of ipilimumab plus nivolumab. This is all based on the landmark CheckMate 214 trial, which showed a massive overall survival benefits specifically in this intermediate and poor risk population compared to sunitinib. So that gives us 4 powerful Category 1 options for this patient group.
And this chart right here, this really drives home why CheckMate 214 was so practice-changing. Just look at the 4-year mark. With Ipi-Nivo, 50% of these intermediate and poor-risk patients were still alive. That is a massive leap from just about 36% on sunitinib. We're not just talking about delaying progression anymore. We're talking about achieving real, durable, long-term survival.
So what happens when even these powerful first-line therapies eventually stop working? Now we're going to look at what comes next, subsequent line therapy, and how we manage those less common non-clear cell types.
All right, so what's the game plan after a first-line IO combo fails? Well, the strategy usually shifts to potent TKIs that hit different pathways. The preferred options here are cabozantinib, which really proved its worth in the METEOR trial, or the combination of lenvatinib and everolimus. And always remember, a clinical trial is a fantastic choice here if there's one available for your patient.
Now listen up, because this is a critical, practice-changing point you need to burn into your brain for the exam. The CONTACT-03 trial looked at patients who had progressed on prior immunotherapy. They gave them either cabozantinib alone or cabo plus an immunotherapy agent. And the result was crystal clear. Adding that checkpoint inhibitor provided zero additional benefit. So the absolute bottom line is, do not continue immunotherapy beyond progression in RCC. Okay, let's talk about the rarer non-clear cell types. The evidence base here is just so much smaller. Because of that, a clinical trial is always the preferred first step. If a trial isn't an option, cabozantinib is a really strong NCCN recommended choice, and that's supported by data from the SWOG 1500 trial. Oh, and also don't forget that temsirolimus holds a unique Category 1 recommendation specifically for patients with poor prognosis non-clear cell disease.
All right, let's wrap this up with some high-yield practice and patient management pearls from BCOP domains 2 and 3. I'm talking about the details that can make a huge difference in patient care and on your exam.
Okay, here is a classic, totally testable TKI toxicity scenario. Your patient on lenvatinib develops a prolonged QTc. What is your first, most critical intervention? What do you do?
The answer is not to immediately dose reduce. The crucial first step is to hold the TKI and correct any underlying causes, like the hypokalemia they got from their diarrhea. So you replace the electrolytes, you review their med list for any other offending agents, and then you repeat the ECG. Only if the QTc is still prolonged after you've done all that do you consider a dose reduction when you restart the drug. This is a massive safety point.
And a final key point on long-term care, please don't forget the bones. With up to 40% of metastatic RCC patients developing bone mets, being proactive with monitoring and using agents like denosumab or zoledronic acid is absolutely critical to prevent painful fractures.
So we'll end here. I mean, think about it. We've gone from having basically one standard of care to having 4 incredible first-line options. The challenge is no longer if we can treat this disease effectively, but how. How we can choose the perfect sequence for each individual patient. And that, right there, is the future of RCC care. Thanks so much for watching.